I'd like to introduce our next speaker, Dr. Geetha Manjunath. Dr. Geetha Manjunath is the founder and CEO of NIRAMAI Health Analytics and has led the company to develop a breakthrough AI solution for detecting early stage breast cancer in a non-invasive, radiation-free manner. Geetha holds a PhD from IISc and a management education from Kellogg's Chicago. She comes with 25 years of experience in IT innovation. She has proposed and led multiple AI projects for Xerox Research, Hewlett Packard India. Before starting NIRMAI, Geetha was a lab director for data analytics research at Xerox India. Dr. Geetha has received many international and national recognitions for her innovations and entrepreneurial work, including CSI Gold Medal, BIRAC Winner Award 2018, and is also listed on the Forbes list of top 20 self-made women 2020. She was awarded the Accenture Wahini Innovator of the Year Award from Economics Times and Woman Entrepreneur of the Year 2020 by Biospectrum India. Geetha is also an inventor of 16 US patents and more pending for grant. She has also bagged the Makers India Award titled Women Make in India in March 2021. Dr. Geetha would be sharing the technical challenges in applying AI to medical imaging and opportunities to make impact, particularly for cancer care. She will also share her learnings from developing and commercializing on AI solution for breast cancer detection. Dr. Geetha Manjunath.
Thank you very much, Mr. Gangadhar. It's a pleasure to be part of this summit of discussing AI and high performance computing, particularly from a hardware perspective. It's a unique combination. As Gangadhar mentioned, yes, I will be talking about use of artificial intelligence in medical imaging, a huge part of healthcare application domain where you consider AI and machine learning as such. Because when we talk about use of AI in healthcare, there are particularly three ways you can use, right? So one is like any other application domain, there's a lot of customer facing activity. How much time did you spend, waiting for your report, how much time were you waiting in front of the lab to get your test done, and so on and so forth in hospital or diagnostic center. So this is the routine operational excellence, which is similar to several other application domains that you will see. The second bunch of them are more in terms of data crunching, with text data crunching, which could be like what you would have heard about, like IBM Watson and all, where you will say, okay, I want to know, today patients are becoming almost as good as doctors to just sort of Google and go to the doctor and saying, why don't you give me these three medicines? Because this is the issue I have, right? So how is that? Obviously, we have this huge web of information that's available. Now, when you have so much of information available on the web, how do we crunch it together and sort of, give it in a capsule so that it is relevant, for the search that is done? So that again sounds very similar to the normal text analysis that is done with other, application domains. So that's the second bunch of application areas with health. Third one is basically where you're using AI or machine learning for actually making a clinical decision, or at least help the doctor make a clinical decision. And that's the clinical decision support, which is basically extremely challenging and also an upcoming field, right, where a lot of real-time information is needed, real-time analysis is needed. And that's mostly what is going to be the focus today. How do we use AI to make really critical decisions that can help doctors make the decision faster or directly, make the decision for the patient? And particularly in that is where we will focus on the medical imaging. I'm sure, each one of you would have seen at least one real medical image, be it yourself or one of your family members. The X-ray, the chest X-ray is the most common medical image that all of us have seen, which is basically the X-ray of the chest area or hand or whatever, right? So that's sort of the one big one. And then also there are several other type of medical images like the CT scans of the world, the ultrasound, the MRI and mammography and so on and so forth. Ultrasound can be for different parts, and so it starts looking different depending upon the probes and all that. So these are actually images that are interpreted by radiologists to say whether something is normal or abnormal. And radiologists definitely need artificial intelligence is the hypothesis. And we'll see an example of where we can actually make this work. One obvious thing is, especially coming in from India, we know that there's a huge shortage of doctors, definitely huge shortage of experts, definitely huge shortage of expert radiologists. And what I was reading is that one radiologist is serving about 1,800 patients in India, 1,800 patients in India every month, I think. So this is a huge load on a radiologist. And what is the radiologist doing? He or she is actually looking at an image like this and making a call as to whether somebody has cancer or not, somebody has broken their leg or not, and so on and so forth, or COVID or not, and so on, right? And this is a visual analysis which requires actual full focus on the image to actually make the right call. And when the doctor is making so many interpretations at a time in a per second, then obviously there could be fatigue and errors in diagnosis. So that we want to reduce. We definitely want to increase the diagnostic accuracy so that there is lower rate of misdiagnosis and improve patient outcome. At the end of the day, if we are able to make the radiologist interpret these more accurately, more faster, at least he or she will also have some time to relax, right? And most importantly, the patient also is going to be happy. Now, why are we discussing these? And this is maybe an obvious need, right? But this is seldom emphasized because we already always talk about 1:1,000 families that a doctor serves in a village. But this, I'm saying, even in an urban scenario, we have this issue, even for an expert specialized area like radiology. And when we're looking at medical images, we all now know, and I think there were quite a few talks earlier in the conference which tell you that deep learning or AI particularly is actually pretty good for visual pattern recognition. The patterns could be, of course, images, video, audio, and sensor data and so on, where there's a whole lot of data available. That's when AI does well. So it's a nice match of need versus demand and need and benefit that AI can bring. There's a few more challenges, that we want to call out when we talk about AI in general and compared to healthcare in general. Of course, some of you would have seen this like 4 V's of big. I think now there's 7 or 8 V's. We can go on adding V's there. When we talk about big data, we talk about volume, variety, veracity, velocity, and so on and so forth. What mostly happens is that when you start building a model, though, of course, the world has a lot of data, the world has a lot of X-ray images, a lot of mammography images, and so on and so forth, MRI, and so on. When you actually start building the data, you will start with very, very small data. So though there is huge volume of data available, the model building starts with very small amount of data. That is because it has to go through ethics clearances, and you need to get data from a particular hospital where you have permission to take, and so on and so forth. There is good variety, but we will focus mostly on medical images. So let's say it's just video and image data. And veracity is most important. What is veracity? Where that is missing or noisy data. Compared to several other domains in healthcare, we do have a huge scope for missing and noisy data. Think about an ICU monitor which is put next to the patient, right? Let's say for some reason the power went off, and then the monitor is started sending 0 as the BP or heart rate. So is it because the power has gone? Is it noisy data, or actually is the person no more? So that's why it's 0. So it's really such a critical information that you have to figure out whether it's actually missing data or really the data is that way, which means it's a high priority information, right? So this is a huge issue in healthcare particularly. And velocity of data, usually we talk about data at rest versus data in motion. Velocity is data in motion, where data is coming in from sensor data, particularly health vitals, like for example, an ICU monitor and so on. So here, how closely you can monitor, how closely you can get the time series data better will be the prediction. But typically, if you're monitoring, there is usually, you don't want the patient to be disturbed so much that, you go on, intervening with the patient's comfort to actually keep on taking data. So you have to balance between how much data you can actually pull out of the patient versus how much you definitely need. So there's so many of these, and the most important ones lifted on the left side, the top and the bottom, is where I want to spend 2 more minutes. One is the imbalanced data set. When we talk about machine learning and training for machine learning, we know that it's all about probability information, learning the, let's say, deep net or even simple probabilistic models to say whether the patient belongs to class A or class B, cancer, no cancer, fractured, no fracture. This is what we're talking about, two-class classification. But typically what happens is, though the models require you to have a balanced data set, equal number of samples in class 1 and class 2, in healthcare particularly, uh, the number of people who are ill is much smaller than the number of people who are well, which is good for the world, but it's actually very bad for machine learning because it results in such imbalanced data. Talking about cancer, right? 0.4% of people can have cancer, which means out of out of 1,000, you may have, let's say, less than 100 people, right? Sometimes even, suspicious is 4%, but actually you turn out to be 0.4 in final biopsy. So it's a huge imbalance of data. So why is that the problem? Let's say you are trying to compute the accuracy of data. You have 100 samples, and let's say 4 of them have cancer. Then it's very easy to develop a machine learning model which gives you 96% accuracy by saying no, 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 right? So it's really not about accuracy. It's also about how do we make things work when the training set is imbalanced, as well as the data you're coming from outside, getting from outside during production release, if you will. That is also very imbalanced. And how do we ensure that we don't miss any cancers, miss any positive cases, despite those being very, very small percentage? So that requires you a huge amount of fine-tuning of algorithms that we need to do. And the last one, which last two one, uncertainty in ground truth. So radiology, right? We see show these images. What happens is that some doctors will say, yes, there is a problem, and some doctors will say, no, there is no problem. So there is an uncertainty in the ground truth because imaging is used when you cannot, or before you can do a pathology. Like its final ground truth for cancer, for example, is to take the tissue test, put it on a microscope, and actually look for those cells. But you don't want to do it for everybody, and that's the reason why you have a proxy, which is the medical imaging. Now, here, the idea, just based on a medical image, you will not be able to confidently say whether somebody has cancer or no cancer. So there is always this multiple ground truth that is coming in. So you have to wait until you actually send them to a biopsy to say whether there's real ground truth or not. What if no radiologist has suspected cancer, but she or he went away with the cancer? Then we have a wrong ground truth already. So there's all of these sort of issues. And finally, feature dependencies, right? We always talk about IID, and some of you who may be working on the AI algorithms, that independent, data points is what we are looking for, right? And in those cases, especially the body is so complex, you're measuring the BP, you're measuring, heart rate, there is some connection. High BP will result in a high heart rate. So these kinds of implicit feature dependencies is very difficult to model many times. So all of this makes developing AI solutions for clinical decision support very, very challenging. And, these are some of the machines, which have very, very smart systems and also embedded computing, which do some kind of live analysis and then throw out only images which actually possibly matter to the radiologist. And that is what we want to kind of, analyze. Now, a particular use case of this is what I'm going to take up today, which is medical images, but what we call as thermal medical images, where we measure the temperature variations on the chest and that variation, because, you can have multiple types of sensing. MRI is magnetic resonance, ultrasound is, the ultrasound, basically sound waves and so on and so forth. X-rays is what you we know what it is, and so on and so forth, right? So this whole electromagnetic spectrum can be used, in MR, also microwave is being used, and so on and so forth. And different wavelengths give you different type of signals about the body. Ideally, you want to scan the multispectral camera and then try to figure out, is there some messages or some signals you're getting in all. But then, infrared imaging is something that we have been working on for the last 6 years now, and we found extremely, interesting patterns here, which is what I'm going to talk about as a case study. Particularly talking about a particular disease which is taking away 600,000 deaths every year, particularly women who are losing their life to breast cancer, which is the largest cancer killer today. And and the unfortunate thing is, many of these people would have lived only if they were detected early. It results in really late detection today because women wait till there is a huge lump before they even come to a hospital. 1.7 million new cases are expected, every year, right? Even especially more so in Asia. And why is this happening? How can we change this, right? So the first approach that most people used and the world knows is mammography, which is using X-rays again for detecting breast cancer, where the breast is compressed between two plates and X-rays are plastering. And this is good. This is mostly used for women above 45 years of age, which are like women here. These are X-rays of two women. And the first one is a 60-year-old and the second one is a 40-year-old. Now you can see that in a 60-year-old, you can actually find this small white spot, which is the high density age area, like a small lesion, which can be suspicious of malignancy. Whereas in this particular case, you have the full whole breast appearing dense. And this is because younger women and women, some women have what's called as dense breast because of higher fibroglandular tissue and so on and so forth. So with this, what happens, how do you actually find this issue within a dense breast? So X-ray fails. And that's again, one place where other imaging methodologies can help and is being used. And more women are younger today when they are detected with breast cancer. So these were missed by mammography, not just in India, but globally as well. There's also affordability, accessibility question that developing world like India needs to answer. A 3,500 rupees test is a lot of money for women to spend every year to detect early. So can we have a more affordable methodology? And I always feel, it's very, it's strange that we use X-rays to detect cancer because as we know, X-rays mean radiation exposure, and more frequent use of the screening methodology itself can increase the risk to the disease which is trying to screen. So it's extremely, I mean, of course, it's a controversial topic, but there are studies which show, for example, mammography-induced cancers and so on and so forth, particularly when there is high risk in the women. So all this, made us look at the new method of detecting abnormalities in the body, which is thermal sensing. Thermal sensing is basically, you would have seen the thermal sensor, infrared cameras, infrared imaging devices in the COVID timeframe for fever detection and all that in airports and so on. It's a similar kind of a thermal sensor which is used on the lady's chest area. And what we have developed is an AI solution over these thermal images, which provides the following advantages. First and foremost, it can detect much before a hand can feel, that is much before a symptom appears, asymptomatic lesion detection, where the lesion can be as small as 4 millimeters instead of 25 millimeters, which a hand can detect. And clearly, it's a stage 0 detection. And we made it extremely non-contact, non-invasive, because this is a camera which can be controlled remotely, as in behind a screen, for example. So it's completely privacy aware, where nobody sees or touches the person during the test. And women really love it because it is extremely privacy aware, like a changing room experience. She has to disrobe, but nobody sees her. And most importantly, like I mentioned, radiation is not great. So this particular solution, basically, it's just measuring the temperature. It's absolutely no radiation. It works for women under 45 as well as above 45, and also on men, because it does not depend on density variations. It depends on the physiological variation, and I'll talk a little bit more about it. And it is extremely affordable, 1/20th the cost of a mammography machine. And so more and more diagnostic centers can provide this and make it more accessible. And it's also very portable. It's like a 1 liter water bottle. You can either give the test inside a hospital or take it out and do the screening outside the hospital. In fact, in COVID time, we have actually started home screening. The technology where we use AI or machine learning for this particular purpose is what we call as thermalytics, thermography or thermal analytics. So when there is a lesion, there is higher metabolism, higher cell division, irregular cell division, which results in an increase in temperature at the point, as well as surrounding the lesion. There is a kind of an abnormal thermal pattern, which is what our software tries to analyze. Analyzing these temperature variations, about 4 lakh temperature points, which are measured per person, we are able to identify whether a person is abnormal, where is the likely abnormality, what is the probability that it is actually cancer. This is a very unique solution made in India, where we have 10 granted US patents and patents in several other countries as well. Here, we are not looking for lumps, which you saw in those X-ray machines, X-ray images I showed. We are looking for abnormal tissue activity, because we are looking at abnormality in the cell division and so on and so forth, which is what is the actual signal of the cancer, right? Whether it is hard or not is kind of an incidental side effect, right? The fact that some cells are behaving abnormally is what we need to detect, and that is what it does. But the key thing here is that thermal cameras are around. We just have to take an off-the-shelf thermal camera, thermal sensor to take these images. And even thermography has been around. People have tried to use thermography to say whether somebody has cancer or not, or some other abnormality, because anything that is hot may be something, indicating abnormality. However, out of 100 people, 60 people will have a red spot. So I mean, here it's basically a heat map. Red or white is high temperature and so on. So you can't call out 60 people as cancerous. So that is where we need this analysis to say which hotspot is actually because of cancer and which one is spurious because of, let's say, hormonal aspects or tight clothing or something. So the core innovation that we were able to develop in our team is basically differentiation of malignant and benign condition, cancer or no cancer condition. You see 4 women here, right? The first one is a normal. The second one has cancer here. And you may assume that, okay, maybe asymmetry between the left and the right side is a way to figure out. But then there are several pieces or, women like this where you will have asymmetry, but she's not cancerous. She has a cyst or hormonal imbalance and so on. So like I said, so that is where you need, some sophisticated analysis. And there are 2 ways to do machine learning here, right? Database analysis and feature-based analysis. And for healthcare particularly, and those of you who are looking at it, you'll see that there's so much literature in medical science and medical literature that, it always helps to take advantage of that. Build a model which has both database decision, that is like a deep learning like model where you just dump the data and then try to do a feature learning and then use it for your machine learning, as well as try to incorporate the knowledge of medical science in handcrafted features, so that you're able to do 2 things. One, you're able to utilize the domain information to make better predictions. Secondly, most importantly, you can actually explain the answer that to the doctor, right? And you can't say, okay, this person has cancer. Why? I don't know. My machine learning model is telling. That's not an acceptable answer. So you need to say, okay, her vascularity is high. Here is, you see some, veins feeding this to this particular lesion, whereas in this other breast it is not. So these kinds of explanations are needed for the doctor to believe. So we had to model it with the more semantic kind of features like asymmetry, thermal distribution of like focal increase in temperature and so on, we call it. And also hotspot boundary, whether there are abnormalities in terms of irregularity called speculations, which is a medical term that the radiologists understand very well, and so on and so forth. So this was one nugget I would like to sort of share. And in terms of classification itself, I talked about issues with ground truthing. So obviously, every machine learning classifier would have a training and a prediction cycle. And what we did was, to figure out what features are needed. Like I mentioned, some of them, right? It has to be semantic features. And more particularly going into this, so one more point here is that also what is the label? For the label, what we did was to actually do thermal imaging of one person and not ask a radiologist whether it is positive or not, because there are no good radiologists who can say yes or no with the thermal imaging today. So what we did was to basically make the person go through thermal imaging, and the same person went through mammography, ultrasound, and biopsy. And we took the biopsy results to actually, train the, train the models. And there are several such features that were used as well. So it's not just about saying whether malignant or benign. We also have several machine learning models throughout the case. For example, when you give an imaging task to a technician, we want to reduce the skill of imaging so that we can have health workers do this, let's say in rural camp. When they do that, they make a lot of mistakes. So now, can we have an algorithm to say whether the image quality is good or bad? Has she taken the right views that are needed? And so on and so forth. All of this has resulted in multiple machine learning models, right? So, and just to sort of give you an idea of where we are, okay. It is actually an install. I mean, it's commercially available. 60 plus hospitals are using, multiple 5,000 plus outreach camps have been conducted, and we actually generate these reports completely automatically using machine learning and AI. And finally, excellent results compared to even mammography, which is a standard of care today, with 100% sensitivity and 93% specificity in screening population, and several publications and regulatory clearances, awards, and so on and so forth. And so this is a learning on the ground of how AI can be used to save many lives. And as a technologist, I feel very thrilled to actually see AI making decisions in rural camps, saying whether somebody needs to be brought to a hospital or not within 15 minutes of the whole end-to-end test. And with this experience, I'm very happy to answer any questions you may have to me.
Hey, Dr. Geetha. Thank you very much for your insights, and I hope you're able to reach out to more people, and especially getting in early detection of breast cancer and helping them, identify earlier. It's a huge thing nowadays that we're seeing more and more. Women are getting cancer early and young, and thank you for enlightening us as a technologist and also giving us your perspective on healthcare and what you guys are doing. Thank you. Next